You know, usually when you get medical advice, especially something as incredibly ubiquitous as just, do your exercises, you assume it's going to help.
Right. You think it's a completely harmless baseline.
Exactly. But imagine doing exactly what you're told, only to find out you are actively causing yourself physical harm. I mean, looking at the sources today, almost half of all people who try to do pelvic floor exercises, like Kegels, based just on verbal instructions from a doctor, do them completely incorrectly.
Yeah, it's wild. And the truly shocking part,
Right, the 25% stat.
yes, 25% of those people are actually bearing down instead of lifting, which is the exact opposite of what the muscle needs.
Oh my gosh.
I mean, bearing down literally pushes the pelvic organs downward under pressure,
Hmm.
which can actively worsen the very issues those exercises are, supposed to fix. It's a perfect storm of good intentions leading to really bad physical outcomes.
It is wild to wrap my head around. But welcome to the deep dive, everyone. We are thrilled to have you with us. Today, our mission is to unpack a surprisingly complex question for you. Can pelvic floor physiotherapy actually prevent overtreatment?
Which is such an important question right now.
It really is. And to get to the bottom of this, we're synthesizing some incredible clinical guidelines from NICE, so that's the National Institute for Health and Care Excellence, and the NHS. Plus, we've got clinical data from specialized pelvic health clinics and leading medical literature dealing with hypermobility and pelvic pain.
We have a lot of ground to cover.
We really do. And I have to say, looking at your background today, the modern clinic setting with the anatomical models and that very serene, calming lighting, it perfectly sets the mood for the shift in care we are about to explore.
Oh, thank you. Yeah, it felt appropriate for today's topic
Mm.
because creating a calm, trauma-informed environment is actually a massive part of modern pelvic healthcare.
Like setting the stage for the nervous system.
Exactly. The space itself has to communicate safety to the nervous system before the physical work can even begin.
Okay, let's unpack this. Because for decades, the cultural messaging has just been drilled into us. If you have pelvic floor issues, leaking, urgency, heaviness, whatever it is, you are conditioned to think your muscles are just weak.
Yep. The classic weakness myth.
Right. And the prescribed solution is always the exact same. It's either a lifetime of clenching and doing Kegels at every red light, or on the totally extreme end, undergoing drastic surgical interventions. I've always just assumed that if you have issues down there, you lack strength.
And that is probably the single biggest myth in pelvic health. What's fascinating here is that the clinical data reveals the real problem is often the exact opposite of weakness.
Wait, really? The opposite?
Yeah, it's too much tension. And recognizing that distinction through proper hands-on assessment is really the ultimate shield against unnecessary, invasive, and potentially very harmful treatments.
Okay, so if it's not weakness, what is actually happening to these muscles? Like, help me understand how a muscle gets so dysfunctional without being weak.
Well, to understand this, we have to look at the difference between a hypotonic pelvic floor and a hypertonic one.
Okay, hypertonic versus hypertonic.
Right. Hypotonic means the muscle tone is too low, it's weak, it's loose, and it lacks the strength to support the pelvic organs. That's the classic scenario everyone imagines. But a hypertonic pelvic floor means the muscles are carrying way too much tension.
Like they're just constantly tight.
Exactly. They are constantly gripped. To visualize this, think about holding a heavy bicep curl.
Okay, so I've got a dumbbell, my arm is pulled up, my bicep is contracted.
Right. Now, if you contract your bicep to lift something, that is a normal, healthy function. But if you hold that maximum contraction all day long for hours on end, eventually that muscle becomes completely exhausted.
Oh, I see. It just gives out.
Yeah, the pelvic floor is a skeletal muscle group, just like any other. It needs to contract to hold back urine or stabilize your core, but it also desperately needs to release to recover.
And what happens physiologically when it doesn't release? Why does it start causing all these systemic issues?
So when those muscles are constantly in a tense state, they literally squeeze the blood vessels shut.
Oh, wow.
Blood flow is severely restricted, which creates a state of ischemia. That's a lack of oxygen to the tissue.
Yeah.
And because the muscle isn't getting fresh blood, cellular waste products and metabolites like lactic acid just start to build up.
Just like when you work out too hard.
Exactly. Your chemical sensors detect this acidic, oxygen-starved environment, and they send massive panic signals to your brain.
So the brain interprets that as pain.
Severe pain, yeah. It manifests as chronic pelvic pain, deep lower back pain, or even severe pain during intimacy. The muscle is essentially screaming for oxygen.
Oh, wait, I have to push back here. Because if the muscle is so tight and it's gripping so hard all the time, Why would that cause leaking or urinary incontinence?
It seems backwards, right?
Yeah, it seems completely counterintuitive. Like, leaking seems like an undeniable symptom of a weak, loose muscle, not a tight one.
And that paradox is exactly what trips up both patients and doctors. In clinical settings, they call it the overlap trap.
The overlap trap.
Yeah, because both hypertonic and hypotonic pelvic floors share almost identical symptoms. Urinary incontinence, a sudden urgent need to pee, incomplete emptying of the bladder or bowels, and that feeling of heaviness.
How does a tight muscle leak, though? If it's fully contracted, shouldn't nothing get past it?
Because an exhausted, hypertense muscle has absolutely no remaining range of motion. Think back to your bicep curl analogy.
Right, the dumbbell.
If your arm is already clenched tight up against your shoulder at 100% capacity, just to manage your baseline daily life, what happens when you suddenly need to lift something heavier?
Well, you can't. The arm is already maxed out.
Exactly. When you sneeze or cough or jump, the pelvic floor is asked to quickly contract further to handle the sudden downward pressure from your abdomen.
Oh, I get it now.
Yeah, because it's already at maximum tension, it has nowhere left to go. It can't adapt. So it fails, and you leak. It's not weak because it lacks muscle mass. It's functionally weak because it is profoundly fatigued from being overworked 24/7.
Oh, wow. So if a patient has urgency or leaking and their doctor assumes it's weakness when it's actually tightness, what happens when that patient goes home and tries to fix it themselves with standard advice?
This is where the danger of misdiagnosis becomes really severe. Clinical data shows that a staggering 60 to 90% of women with ongoing pelvic pain actually have hypertonic overactive muscles.
60 to 90%. That is huge.
It is. So if they go on the internet and Google tells them to, do more Kegels, they're doing intense contraction exercises on muscles that are already starved for oxygen and completely exhausted.
They're basically clenching an already clenched fist.
Precisely. It makes the dysfunction exponentially worse.
Yeah.
It increases the ischemia, worsens the pain, exacerbates the urgency, and it just drives the patient down a terrible rabbit hole of seeking heavier medical interventions.
Because they think they're failing.
Right. They think, well, I did the exercises for months and I'm worse. My body must be broken. I must need surgery or lifelong medication.
And that leads straight to overtreatment, which is exactly why guessing your diagnosis is a one-way ticket to poorly targeted care. Because the symptoms overlap perfectly, you just can't self-diagnose.
You really can't.
And it's not just a matter of tight versus weak muscles either. Looking at the sources, Dr. Farzana, who's a leading voice in pelvic health, discusses the integrated dual realities of the pelvic floor, pointing out a critical difference between muscle weakness and structural tissue laxity.
That distinction is paramount. People forget the pelvic floor isn't just a layer of muscle.
Right.
It is a highly complex hammock made up of active muscles, yes, but also passive structural components. So ligaments, collagen, and endopelvic fascia.
So if I'm understanding this right, relying on muscle exercises to fix a structural tear is sort of like trying to fix the cracking concrete foundation of your house by, hiring a personal trainer.
That is an excellent way to visualize it. You cannot flex a ligament.
Right.
Standard exercises, like Kegels, can restore active muscle tone. But if your issue is structural, meaning the collagen itself is overstretched, or the fascia is actually torn, which often happens from the mechanical trauma of childbirth or the hormonal shifts during menopause, no amount of squeezing is going to shrink or retighten that connective tissue.
So how do you actually fix the structural side if exercises just don't work?
Well, structural tissue laxity requires entirely different interventions. On the conservative side, you have mechanical supports, like vaginal pessaries.
Like physical inserts.
Yeah, these are medical devices inserted to physically prop up the pelvic organs, acting like internal scaffolding so the muscles don't have to work so hard. And on the more advanced side, there are energy-based thermal remodeling treatments, like specific medical laser therapies.
I've always wondered about that. How does a laser actually tighten tissue?
It uses controlled heat to create microscopic thermal injuries in the deeper layers of the vaginal wall.
Sounds intense.
It sounds it, but it triggers the body's natural healing response.
Yeah.
It stimulates fibroblasts to produce fresh, new collagen and elastin, which effectively shrinks and tightens the non-muscular layers.
That is amazing.
It is, but without a specialized physiotherapist doing a proper assessment to distinguish between neuromuscular weakness and structural connective tissue damage, you might undergo a major surgery to fix what is actually a solvable muscle tension issue.
Or the opposite.
Right, or you might endure painful muscular therapies that will never work because your underlying issue is actually a structural tear.
Man, the complexity of all this really hits a peak when we introduce systemic hypermobility disorders into the conversation. Because here's where it gets really interesting. Let's talk about Ehlers-Danlos syndrome, or EDS, and hypermobility spectrum disorder, HSD.
Oh, this is a crucial piece of the puzzle that often gets missed entirely.
Yeah, the sources get pretty deep into this.
People with EDS or HSD have a genetic mutation in how their bodies build connective tissue. So their collagen is inherently fragile, overly elastic, and prone to micro-tearing. And why this matters so deeply in pelvic health is that for these patients, pelvic floor issues rarely exist in a vacuum.
Right. The clinical data points out that hypermobility is frequently accompanied by a cluster of other conditions, specifically dysautonomia like POTS, so postural orthostatic tachycardia syndrome, and MCS, mast cell activation syndrome.
Exactly.
But for a listener who doesn't have a medical degree, why do a heart rate condition and an immune issue directly impact how tight your pelvic floor is?
It all comes down to the nervous system.
Yeah.
POTS is malfunction of the autonomic nervous system where blood pools in the lower body when you stand, and that causes a massive spike in heart rate.
Okay, so the heart's racing.
Right. And MCS is an immune disorder where mast cells misfire, flooding the body with histamine and causing severe systemic allergic inflammation.
That sounds incredibly taxing on the body.
It is exhausting. Because their cardiovascular and immune systems are constantly misfiring, a hypermobile patient's nervous system is perpetually stuck in a state of fight or flight.
Oh, wow.
And when your nervous system is panicked, your body subconsciously clenches. The pelvic floor often becomes the tension-holding tank for all that systemic distress. So you absolutely cannot use a generic one-size-fits-all strengthening protocol on them.
Because if you just throw Kegels at a nervous system that is already maxed out on defense, you'll just cause more pain.
Exactly. A trauma-informed physiotherapist knows that for hypermobile patients, the cornerstone of management is releasing nervous system tension before you even attempt to build strength.
Which makes total sense.
Furthermore, if a surgeon isn't looking at the whole systemic picture of their hypermobility, they might offer a promised surgical repair, like a prolapse mesh or a suspension surgery, that the patient's fragile elastic tissues simply cannot support long-term.
The tissue would just tear again?
Yes, the surgery will likely fail, leading to repeated, highly traumatic interventions.
It's really about protecting the patient's consent by having an honest, scientifically grounded discussion about what their specific tissues can and cannot handle.
100%.
So if we know that guessing leads to overtreatment and generic advice causes harm, how do you actually assess this safely? Like, what does a real physiotherapist do? Because I think a lot of people still assume physio just means a doctor handing you a generic pamphlet of exercises while you keep your clothes on.
That is a very common misconception. But modern pelvic floor physiotherapy is highly clinical, deeply specialized, and incredibly interactive.
Let's demystify that process. What are the actual tools of the trade?
Well, first, there's internal palpation. The physiotherapist actually assesses the resting tone of the muscles internally.
Oh, okay.
Yeah, they are trained to feel the exact tension of the pelvic floor to definitively tell you if you are dealing with a tight muscle, a weak muscle, an asymmetry, or a structural prolapse. Then they utilize biofeedback, which is honestly entirely revolutionary.
How does biofeedback work in this context?
Because the pelvic floor is hidden inside the pelvis, many people who suffer from dysfunction have completely lost their proprioception. Their mind-body connection to those muscles.
They literally can't feel them.
Right. They honestly cannot feel the difference between contracting and relaxing anymore. The brain has just muted the signal. So biofeedback uses surface sensors or even real-time external ultrasound placed on the abdomen or perineum.
Wait, so you can actually look at a screen and see a visual representation of what your pelvic floor is doing in real time?
Yes. You can see the graph spike when you contract, and more importantly, you can watch the line drop as you learn to consciously relax.
That is so cool.
It visually reconnects the brain to the muscle. And once the assessment is clear, they use techniques like myofascial release. The physiotherapist or even the patient at home using specifically designed S-shaped pelvic wands applies sustained, gentle pressure to internal trigger points to release the tight fascia.
So it functions very much like a deep tissue massage. You might get to work out a painful knot in your shoulder, but targeted internally to the pelvic floor.
Precisely. You have to physically release the ischemia and tension before the muscle can function normally again.
Okay, I have to ask a skeptical question here, though. Let's say my primary problem is urinary urgency. I am waking up every single hour of the night feeling an overwhelming, painful panic that I need to pee.
Okay, very common.
How is massaging a pelvic muscle or looking at an ultrasound screen going to stop my bladder from panicking? That sounds entirely like a bladder organ problem, not a muscle problem.
It's a brilliant question, and answering it reveals the incredible neurology of the
I'm
pelvis.
intrigued.
The bladder and the pelvic floor are not isolated systems. There is a well-established spinal mechanism called the guarding reflex.
The guarding reflex.
Yes, your pelvic floor muscles and your bladder muscle are in constant communication via a direct highway through the spinal cord.
Like a neurological feedback loop.
Exactly. When the bladder fills, it wants to empty. But if it's overactive, it starts spasming prematurely. However, voluntary contraction of the pelvic floor muscles actively sends an inhibitory signal up the spinal cord that literally tells the bladder muscle to stop spasming and relax.
Wait, really? Flexing the pelvic floor turns off the bladder?
Yes, it's amazing. A foundational study by Shafik and Shafik demonstrates this beautifully. They found that a voluntary, correct contraction of the pelvic floor muscles reduced internal bladder pressure from 28 centimeters of water down to just 11 centimeters of water.
Whoa, that is a massive, immediate drop in pressure.
It is more than a 50% reduction in the mechanical force pushing urine out. And simultaneously, it increases urethral pressure to hold everything in. In plain terms, correctly engaging your pelvic floor actively suppresses the micturition reflex, which is the biological urge to pee.
Wow. So by learning to control the muscle, you are literally hijacking the nervous system to calm the bladder organ down.
Yes. Another key study found that pelvic floor muscle contraction completely eliminated involuntary bladder contractions in 47% of women with overactive bladders.
Almost half.
Yeah. But here's the catch. You can only utilize this incredible reflex if you have been trained to contract correctly at the right moment and without bearing down.
Which brings us right back to why the assessment and the visual biofeedback are so absolutely crucial. If you are just guessing at home, you can't trigger this reflex.
Exactly. And this is the core of how proper assessment prevents overtreatment. If you successfully utilize these non-invasive, conservative physiotherapy methods to trigger the guarding reflex, you completely avoid the medical cascade.
The overtreatment cascade.
Exactly.
Yeah.
You don't end up on lifelong medications like anticholinergics, which are often prescribed for overactive bladders, but come with terrible side effects.
Right, like
Severe dry mouth, cognitive brain fog, and chronic constipation, which ironically makes pelvic floor tension even worse.
yeah.
You also avoid invasive procedures like getting needles to inject Botox directly into your bladder wall to paralyze it.
Oh,
And you avoid major surgeries. You are treating the root functional cause of the nervous system miscommunication rather than aggressively masking the symptoms with heavy medicine.
And what's so encouraging is that this isn't just a theory for individual enlightened physical therapists anymore. If we connect this to the bigger picture, the entire medical establishment is currently rewriting the rulebook to prioritize this exact preventative care.
It really is a massive systemic paradigm shift.
Look at the NICE guidelines, which govern the highest healthcare standards in the UK. They recently released comprehensive updates explicitly recommending supervised pelvic floor muscle training as a mandatory first line of defense.
Yes, finally.
I mean, for a diagnosis of pelvic organ prolapse, they don't recommend a quick chat. They mandate a supervised physiotherapy program for at least 4 months.
Which is huge.
And parallel to that, the NHS is actively rolling out perinatal pelvic health services, or PPHS, across England right now.
And the cultural implications of these guidelines are staggering. Think about the historical context here. For generations, women were told that leaking when they jumped on a trampoline or having pain after childbirth or feeling heaviness as they aged was just a normal part of womanhood.
Yeah.
The prevailing medical attitude was, buy some pads and just live with it.
Or, on the flip side, the moment they complained, they were rushed into a surgical intervention, but often told they had to wait and suffer until their family planning was entirely complete.
Right.
Like your physical comfort didn't matter until you were done serving your purpose of having kids.
That medical gaslighting was standard practice.
Yeah.
But the new guidelines explicitly dismantle that. They state that conservative management, meaning specialized, supervised physiotherapy, must be discussed, offered, and attempted before any surgical interventions are considered.
It's such a necessary shift.
It is moving from being a fringe, alternative lifestyle option to being the absolute core of gold standard care.
The NHS documents actually state that the goal of these new specialized clinics is to change the dialogue, They want to move away from confusion and accepting dysfunction as normal to creating a baseline expectation of specialist care.
As it should be.
They aim to identify issues antenatally so before the baby is even born and provide funded support for women for at least 12 months after birth.
And importantly, it is not just for postpartum women. The guidelines advocate for integrating pelvic floor education for girls starting as early as age 12.
Oh, that's amazing.
This is about treating pelvic health as a fundamental life course issue, not just an occupational hazard of pregnancy.
So, what does this all mean for the future of healthcare? It means that physiotherapy isn't just a nice-to-have add-on or a hoop you jump through to get insurance to pay for surgery. It is the primary destination for healing. And beyond just physical recovery, it actively protects the patient's bodily autonomy. It gives you the diagnostic tools to truly understand your own body's mechanics, rather than just handing your body over to a surgeon to blindly fix it.
And we should absolutely note, while the NHS rollout focuses heavily on perinatal women because of the trauma of childbirth, pelvic floor dysfunction affects everyone.
Right.
Men suffer from hypertonic pelvic floors at staggering rates too, though it often manifests as diagnoses like chronic prostatitis, chronic pelvic pain syndrome, or sexual dysfunction.
That makes total sense.
The physiological rules we've discussed, the need for proper assessment, releasing ischemia, biofeedback, and neuromuscular retraining, apply across the board, completely regardless of anatomy.
Which brings us back to you, listening to this right now. Why does a deep dive into pelvic floor mechanics matter to your daily life? Well, whether you are dealing with unexplained pelvic pain, urgency, or leaking yourself, or maybe you are supporting a partner through a difficult postpartum recovery, or you simply want to be an informed advocate for your own long-term health, the key takeaway today is empowerment.
Because having an accurate map of how your body works is the most powerful tool you can possess.
It truly is. Understanding that a tight, exhausted muscle can perfectly masquerade as a weak one is a complete paradigm shift. Knowing that 50% of people do these exercises wrong on their own proves that struggling to fix yourself isn't your fault.
No, not at all.
And realizing that a specialized pelvic health physiotherapist can decode all of this complexity for you, that saves you time, it saves you money, and most importantly, it saves you from the unnecessary physical trauma of overtreatment.
This raises an important question, and it's something I want to leave everyone chewing on. Today, we've talked in depth about how you can literally rewire an involuntary reflex-like, overwhelming, painful bladder urgency simply by using mindful biofeedback and muscular downtraining to calm the nervous system.
Literally hijacking the body's hardware for the better.
Exactly. So, what other inevitable physical declines or chronic pains that we just blindly accept as we age are actually just a matter of neuromuscular miscommunication?
Oh, wow.
How many other conditions in the human body are we surgically cutting into or suppressing with heavy medications that are really just waiting for us to decode the nervous system's distress signal and simply release the tension?
What a profound thought to end on. It completely changes how you look at the resilience and the logic of the human body. Thank you so much for joining us on this deep dive. Remember to trust what your body is feeling, demand proper, thorough assessment before agreeing to extreme treatments, and as always, keep questioning the obvious. We'll catch you next time.